Our job as bioethicists is to address today's and anticipate tomorrow's ethical challenges in public health, in science, and in healthcare, to help find answers to the biggest questions that affect us all.
If it were true that you had a dramatically increased risk of developing Alzheimer's disease, would you want to know? Well, the human genome was completely sequenced in early 2000s, and this information gives us the ability to predict disease with some level of confidence, to begin to tailor care in a way that we haven't been able to in the past.
But genetic information is inherently probabilistic. We don't know if people will ever actually develop disease, and there's a lot we might know about our genetic makeup long before there are interventions that can be offered to us that are effective.
So the kind of work we do at the Berman Institute is critically dependent on our relationships with the scientists, because we try to be proactive in addressing emerging technologies, science that's at the cutting edge. So genetics, stem cell science, synthetic biology, nanobiotechnology, all areas that don't necessarily raise brand new ethical issues, but raise them in ways we've never seen before. So, for example, we do not currently have the policies in place, the capacity to deal with the flood of genetic information that's coming down the pike. And we need to start making decisions about incidental findings, about the communication of results. And it's quite critical that we do this as soon as possible.
At the Berman Institute, we use the tools of the social sciences to capture the experiences and attitudes of many rather than reacting to a single story. We use these empirical data to test theory against reality.
You have these flashes of lightning, sharp shooting pain that shoot through the steady beating, pounding pain for weeks upon end. This is the pain of sickle cell anemia. And yet sometimes when we go to the emergency room to seek treatment for our pain, we are treated as if we are drug seeking, that we're seeking to use these narcotic medications for reasons other than legitimate medical reasons. 1 out of every 400 African Americans is born with some form of sickle cell, and this disease can serve as a wonderful model for how we can address the larger issue of racial and healthcare disparities in the United States. There is a long history of individuals of African American descent not being treated with the amount of respect that all patients deserve. And the issue of trust is so important in the healthcare setting. So we actually talk to individuals with sickle cell disease, conducting research on better ways that we can educate healthcare providers, and so that some of the stigma that's associated with sickle cell disease can be diffused.
The Berman Institute is at the forefront of our national conversation on bioethics, translating what we learn at the bedside into sound public policy.
Often the family was going through a totally normal pregnancy until the day that the mother went into premature labor, somewhere between 23, 24, 25 weeks. And so all of a sudden the family is facing doctors who often they've never met before, saying, we need a decision, and we need a decision today, and maybe we need a decision right now. And I can totally understand why a mother or a father would say, do everything you possibly can to save my baby. At the same time, if in reality we know that the chances of us saving that baby, saving the life, or saving a good quality of life is extremely low, like 2 or 3 or 5%, it's not clear that that's in the best interest of the baby.
But also in pediatrics, as well as at the other end of life, when people lose capacity, we're really left with the same question. When a person can't speak for themselves, then who will speak for them? Who has the authority when the answers aren't clear-cut?
And how to reconcile those things is basically a daily challenge for anyone who's doing this work.
The Berman Institute, since its inception, has taken on the ethical issues in improving the health and life prospects of entire populations, particularly the world's most poor and disadvantaged.
chances are, if you're taking a medicine for a particular disease, let's say right here in Baltimore, it has been tested in the developing world. Increasingly, pharmaceutical agencies in particular are finding that their capacity to do early stage testing of clinical drugs is often easier in the developing world for a wide spectrum of reasons. Economics, ease of finding volunteers, ease of dealing with the regulatory processes that are in place. But in low-income country context, and particularly when we are dealing with vulnerable populations, then we are concerned about issues of, for example, exploitation. Having research studies conducted in areas where people are, for example, poor, at the same time they are uneducated, at the same time they are politically powerless. And this creates a cycle where their ability to negotiate with researchers or with research funding bodies might be vulnerable to other influences. And the point about the burden of risk is indeed very important, because very often the initial recipients of that benefit are people in high-income countries simply because they can afford to do so or because their health systems can afford to implement that for populations. So we want to be sure that from an ethical perspective, those studies are conducted with the full information and consent of study populations, and we want to make sure that the populations that they are conducting research in, at some level, achieve some benefit.
Bioethics is central to our role as a modern research university. We train physicians and nurses side by side with the leading humanities scholars to address the complexities of the human experience.
A lot of the things that bioethicists deal with involve the practices of doctors and public health practitioners and nurses, but it's also important to consider the implications of advances in biomedical technology for our understanding of ourselves. So for instance, neuroscientists, some of them are trying to explain the particular kinds of brain function that underlie the exercise of self-governance. It's using fMRIs and various kinds of imaging techniques to try to figure out what exactly is going on when we make a decision. They've discovered that the brain activity that's associated with making the selection, it begins before the people register that they're making a decision. And the danger is that people might think that if we understand everything about why you did what you did, then it would turn out that you're not responsible for what you do. And that would have enormous moral ramifications.
Clearly, this is a new era in the field of bioethics. Our spheres of influence are ever changing, ever expanding. And at the same time, with our new building, Deering Hall, the Institute now has a home where our community of scholars, clinicians, and scientists can work together to help solve the increasingly complex bioethical issues we all face in our families, in our nation, and around the world.